Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Welcome to this episode of the Skin Sync podcast. My name is Shannon Moranti, and I'm a dermatology PA from Naples, Florida.
And I'm Buccinita, dermatology PA from the Atlanta, Georgia area.
And we are so excited to be joined by a friend and colleague, Ellen Toneff, who is a dermatology PA from the Tampa Bay area here in Florida. And she is the clinical curriculum coordinator and lead APP trainer with Suncoast Skin Solutions. Ellen, welcome, and thank you so much for joining us.
Thank you for having me.
Excited to have you on the podcast today. And you're going to be chatting with us about clinical charting and note documentation, the bane of my existence for sure, and probably many of you listening. So let's dig into it.
Yeah, so one of my favorite parts of what I do is helping new providers build solid foundation in their practice. So I'm also the treasurer of a nonprofit, Sunrise NPPA Derm, focusing on caring for patients and also caring for ourselves as providers too. And that is one of the reasons why I like medical documentation. It's not because I love paperwork. It is not, I promise. It's because I know what good charting is, what keeps patients safe, and what keeps my clinic flowing smoothly, my MAs happy with me, and helps us get the outcomes we want. And I don't like spending a lot of time at home doing charting. So the more I can put in to build that foundation and teach others to build that foundation, so that they can kind of coast with their charting and keep up with their patients. That's what I really love.
I know that there's so many providers, including myself, that go home at the end of a very busy day and we have mountains of charts to review, like so many. I am almost embarrassed to say how many open notes I have at this moment and how many I need to go back and review. What can we do as providers? And I know this is a loaded question, but are there ways of making our charting more efficient? Are there ways to kind of streamline this process to make things work better, work more smoothly, so that we can actually take the time to take care of patients and not sitting there on our iPad or on our desktop at the end of a busy day?
Yeah, so taking care of the patients during the day and taking care of ourselves after, so we don't have to do that at night. So my big thing is that we're a lot of times spending time after hours going like, retroactively, looking back through charts, and that's where we're spending a lot of our time. And if you think about how that works moving forward, if we were to spend that time researching the actual charting system and putting our notes down in ways that we can repopulate them and kind of efficiently go back in and make them, like I said, efficient, we could spend that time beforehand and not have to do it afterward. Um, so that we can make the notes how we want them to look. I use Emma. So there are a lot of tips and tricks in Emma, and I'm sure there's other tips and tricks in when we used to use Nextech a couple years ago, and other charting practices. Yes, I used to have a Google Doc when I didn't have Emma, and I would copy paste things from the Google Doc to that weren't in the charting system. I mean, there's different ways that you can do it to where you can streamline it, even if you don't have one of the more popular ones. And you can make your MAs not hate you while you're doing it.
I will say that I am probably not one of the favorite providers in the clinic to work with because number one, I'm a stickler for documentation. And two, I have some complex patients sometimes. And so they really do get frustrated. So I definitely am looking forward to hearing some really good tips on how to chart more efficiently. One question I did want to ask you, though, is really for providers who maybe don't spend that much time documenting and maybe they have very scanty chart notes. What are the risks? What are the dangers of doing that? Why is it important that we have really thorough and detailed documentation?
So risk wise, I mean, there's the legal risk, right? So there's if you're not going to look back at your note, who is writing that note, right? How trained are your MAs? If they're working with you every day and they see that you don't care about your notes, they're not going to care about their notes or the notes as well. So you really don't have anyone caring about the notes. And the notes are the documentation that paper trail for your patient. So if it did come down to something legal, if it's not in the note, then it didn't happen, right? So sometimes that's a good thing. You don't want to over document, but most times it really doesn't do the patient any good. They're coming to see you time after time and you're not looking at their note, not following up where you left off. Sometimes you're just spinning their wheels, and you're spinning your wheels too. It's kind of like work smarter, not harder. If you kind of make a trail from where you were last time and make it readable, and the next MA that comes to work with you can read the last note and not just, sometimes we have MAs that don't are on our team, or people who try to help, but they don't know what you were doing last time. You need to leave breadcrumbs for yourself and for your MAs and for your patients to know how to move forward. The risks of that are legal, yes, but there's also risks of your patient not getting the outcomes that you know how to get them. It's just you need to document. Until you can get them there.
So I think everyone listening to this podcast is so hungry for some really good tips and tricks on how we can make our documentation more efficient, more effective. How can we potentially kind of position ourselves to have better patient care, better continuity of patient care, and better clinic flow? What are some tips that you would say? And I would, again, Bucci and I are going to be so excited to pick your brain tonight on
Um,
some specific tips on Emma. And for everyone using Emma, please listen in and get out a pen and paper and start writing this stuff down. But even for those of you who don't use Emma, dive into your EMR. I think it's very important to learn your system and to learn the nuances of your system. But when specifically speaking about Emma, why does documentation matter, and what's the best way that a clinician can really take charge of their own documentation?
yeah, so I am super nosy. Like, I will just go out and say, "I'm so nosy." If someone has some tea, I wanna know the tea. I wanna know the charting system just like that. I wanna click around and make my note look the coolest that it can. Just like if you're, like, website designing or something, that like, these design your notes, right? So, like, you can make your notes look how you want them to, you just have to learn the system, right? So, like, the new iPhone upgrade or update or whatever, you eventually learn that, you have to. But if you kind of stay ahead of it, you can kind of find the coolest gifts to send to your friends. You can be like the cool kid on the block, right? So you want to be that person in your EHR, right? Like, so Emma, you want your notes to look awesome, um, and shoot for the moon. If you don't, you'll land up on the stars. But there's a bunch of built-in tools and protocols, specifically in Emma. Yes, I can talk about that all day. But you spent time clicking around, right? There are countless videos that you can watch on Emma, and you don't even have to do videos. There's those practice updates that are on the corner of your screen every other month that pops up. Click on that and read what the new updates are. You don't have to go to the Emma conference or the EHR conference once a year, right? You can kind of like learn it with your team. Ask your MAs. Your MAs are the ones charting. If they find something cool, say that's awesome and roll with it, right? So there's templates, macros, order sets. You spend an hour doing a protocol, it'll save you hundreds of hours later on. I have protocols on surgeries, on Accutane. I have 5 Accutane protocols. I have female before the 30 days. I have female as the start. I have female as the follow-up. Then I have male as the start and the male as the follow-up. Let your MAs do less clicks and you can go have them help you out somewhere else later on, right? So another thing about that is it's not just your EHR. Show your team that you care about the notes, that you wanna learn about the notes, and they will wanna learn too. Praise them for really good HPIs, that they ask the right questions, that they're clicking the right buttons. There are specific HPIs, like, that you can click on in Emma, and I know that this was the fact or, the case in Next Tech as well, but there's a melanoma follow-up HPI. There's a biologics one. It's not just one of them. You type in a specific biologic or a specific medication, and it'll pre-populate the most pertinent questions for you. So before you even get into the room, your MA is asking those questions, right? Isotretinoin, it asks all the Emma is smart. These it's called electronic medical assistant. Like it's doing the work for you. Let it do the work for you. You just have to figure out the buttons to press.
Yeah, I love that advice. So, really talking about the HPI and these chart notes, I think it's really important to emphasize to our MAs that it's the pertinent positives and pertinent negatives in the HPI are really, really important. Emma does a beautiful job of that. If you pull a kind of a generic follow-up visit oftentimes will not prompt you to ask those questions. So I love that advice. So let's kind of dig into the protocols a little bit more. So how are you utilizing them? What's the purpose of protocols? What can you enter into a protocol? You mentioned that you have 5 different ones for isotretinoin. Can you give us a little bit more detail on that?
Can give you a lot of detail. Have to reel me in. Yeah, so the protocols, specifically in Emma, are ways that you see a patient and you do basically the same thing every time. You build yourself scaffolding, right? You build yourself this network of, okay, I can set it up and then I can put in patient information where it's pertinent, right? So if you're seeing a patient for, let's say, isotretinoin monitoring, right? You could just pull in acne without a protocol, acne, and then the plan as isotretinoin monitoring. That's pretty good, right? Like that's at least you're doing the right thing. But if you pre-set up that you have the pregnancy tests that you're doing, which labs you already want ordered, what counseling you have, male versus female, do you prescribe them birth control or not? Do you have birth control counseling on there? If you don't order labs every month, do you still want to counsel them on it? How many times do you want the labs ordered? At what month do you want them ordered? Your MAs can't read your mind and they shouldn't be able to. That would be bad. But like, what is your cumulative dosing? Do you even go by cumulative dosing? Like, what do you want to set this patient up to where no matter who comes on your team, they know your plan, right? And you know your plan, and the patient knows the plan, right? So, like, you're taking time to set up the correct counseling. What did you actually talk to the patient about, right? Did you talk to them about headaches, blurred vision, abdominal pain, nausea, vomiting, suicidal thoughts, that kind of thing? Or do you not talk about that every single time? Like you need to put that in the note and you can pull it over from note to note, but set yourself up for what you did and what you're going to do so your MAs can follow and they know like your next step. They don't have to read your mind, they can read your notes.
Yeah. Wish that this was a sorry, that just slammed to the ground there. That was a little loud.
You're just so
Um,
excited.
I know, it's so I wish this was a visual podcast for specifically this episode because I wish you could take us through your beautiful PowerPoint presentations. I know you have spoken about this on Podium, and I know you have some amazing examples exactly how we should lay things out. But if you can kind of verbally go through for somebody listening who might be driving in their car, who might be like furiously scribbling down notes. How do they even start setting up a protocol? Because that's not something that comes with Emma in the prepackaged version with a little bow on it. Like, how do they start setting up a protocol that is specific to their wants and needs?
So that's a great question. And I will say that I don't know how it is for every EHR, but Emma has a community where it's at the top right of your charting system. You can click it or you can click help, and there's videos on it. I mean, these videos are less than 5 minutes. It's not some long drawn out video that you play in the background, right? They're very mindful about it, but I will walk you through kind of setting up a protocol in the quick and dirty, right? So you go into there's a space in Emma where you can set it up. So I'll just skip that part. But you go into a test patient's chart or a protocol chart. You pull in the diagnosis you want, you pull in the plan you want, and then you start doing exactly what you want with the plan, right? So I pull in acne. I pull in the inflammatory papules and pustules located on the face. So I know what the diagnosis is. I know what the morphology is, right? I have an associated diagnosis of high risk medication monitoring, and my status is, or their patient status is inadequately controlled. That's my Accutane patient. Then I pull in the plan. So that was just the diagnosis, the morphology, the associated diagnosis. Then I pull in the plan of counseling. So I have counseling and it's usually on the face. And if not, then I can add it to the back, whatever. And it has pre-populated skincare, expectations, contact office if, blah, blah, blah. So that's already pre-populated in the counseling. Now I do prescribe birth control. So I'll pre-populate that in there as well, my birth control counseling, because I do talk to them about it. Sometimes we forget that you're um, prescribing both. You really should be asking about both sets of side effects, right? So that's my counseling block. Then I have my prescription medication management block, which just says this is my also for context. This is my isotretinoin follow up for females. I have my plan is prescription medication management. Continue isotretinoin course. That's just my overall plan, right? So the nitty-gritty of that is it's isotretinoin monitoring, right? This is where the details come in. It has months of therapy. How long have they been on the therapy? And then it says dosage month 1, right? So I just have dosage month 1, and then I can pull this, note in and pre-populate 1 and then pull it from the next one, and it already have 1, so I add it to 2, and then I add it to 3. So every time I can add on to this one. So the setup is just the first month, 20 milligrams twice a day. Next month's dose, increase to 30 milligrams twice a day. Sometimes I do that, sometimes I don't. Either way, it's there for me to click to change. I have my treatment protocol in there, 1 mg per kg until a cumulative dosing of 120 to 150 milligrams per kilogram is reached. Now, sometimes I'll alter that. Really, it depends, but that's overall what is populated in there. And I have my patient counseling on isotretinoin. Now, this is a huge chunk. It has alcohol use, vitamin A supplementation, it has risk of fractures, liver damage. It has a lot of things, and I do talk about this every single time um, to my patients. I want to make sure that they understand it as well. It also has when they're to stop taking the medication and call the office immediately if you have these side effects. I have the specific counseling that iPledge wants me to talk about. Should not get monthly blood tests, should not donate blood, should not drive at night if affected vision, and should not share the medication. Female patients should also be on 2 forms of birth control while taking this medication and for 1 month after their last dose. So there's my specifics. That's a legal thing. I mean, all of this is, but and then I said I answered the patient's questions and the patient expects understanding of the above risks. They're to call if they have any problems. The action items was that patient was confirmed in iPledge today. There is another action item that also says patient was sent in prescription today. Um, I also have plan order tests, lipid panel, hepatic function panel. Depends on if I order the birth beta HCG. And I put a specific clinical notes lab. I do not get labs every single month. Sometimes I make a note to myself that I do or don't do that. Depends on the patient. But I put a spot in there for myself to make note of that so that, again, I'm making a scaffold for myself.
It's great to know that you can adjust it. So even though your protocol might be exactly the same way for every Accutane follow-up, you're still able to go in there and change those action items. Maybe they're at the end of their therapy. And yes, maybe that isotretinoin monitoring has been calculating everything, which it does. It calculates your cum dose. It calculates everything for you, which is so wonderful. But I think a lot of us get into the weeds with protocols and we get worried that every note is going to look exactly the same. But we shouldn't be scared of that, right? We should
Well,
know that we can go in there and adjust it.
you should, because not every patient is the same, right? You don't treat every single patient the same. I mean, it's like patients, you go off of the textbook, but they are not textbook, right? So you can definitely you should alter every note, but it is so much easier to alter a note than it is to start from scratch. You don't want to have to start from scratch every time. You can utilize that scaffold. You can utilize those notes, that outline, and change it per patient. That is very easy to do. And it's easy for your MAs to make small changes as well. But make sure they know where you're changing. My MAs, it's kind of funny. They know that I can just whatever is right for that patient. It's not that I have the same plan of action every single time. So it's a little bit harder to follow me sometimes than other providers, but I think that's the best way to treat my patient is that's how I would want someone to treat me, right? Is that I'm an individual. I'm not a protocol, right? And they're not, but I can use that, right? We can definitely use it as an outline.
So, really great tips today. I just want to summarize a couple of them. So, number one is for the HPI, really trying to utilize diagnosis specific HPIs, which will prompt you to ask the right questions to your patient. Creating protocols, I will say that I definitely do not do this, at least don't do it enough. And I think it's costing me a lot of time in clinic and a lot of frustration. So I think that is something as of tomorrow, I will start generating some some protocols to use in my clinic and also utilizing the help button. I don't think I've ever clicked it ever on Emma. And so utilizing the button to watch videos and learn more about how to utilize the system, but I definitely think I'm underutilizing Emma and it's really costing a lot of time. Any final tips that you have to share with our listeners? Any other important things that we need to know about documentation?
I would say try to figure out where in Emma, it's called the historical summary is. You can pull little tidbits from note to note. For example, my patients that are melanoma patients, I write down they have melanoma, when it was, and so my MAs never forget to ask. It's really, if they have melanoma, subderm, if they have a history of BCC, SEC, they know they don't have to look back into notes. That's my expectation that I want to talk about that every single time. That Accutane patient is not going to be on Accutane every single time, but that patient is going to have melanoma every time, right? So that is something that's really important. Find that place where you can have a small reminder in the chart about what you want to talk about next time and every time.
Where does that populate in the note? Because I don't use historical summary. Like, I love that idea. I love that just as, again, breadcrumbs, just as something that can kind of travel from note to note, depending upon what MA you're working with. Like, it can be variable so much from visit to visit. So where does that historical summary populate? Where do you put that?
So the historical summary, you can find it in the same place that you write the HPI. So it's in that same drop down, at least in Emma, the ROS, that, and you can choose whether it populates in the note or you don't want it to be in the note. So if you want the patient to be able to see it or not, I choose to put it in the note because I want, even if I'm looking at past notes, to see what was added, right? So it populates right after the HPI. So it's just a
Cool.
small section right after the HPI. It's very, very, very useful.
So you'll utilize that instead of utilizing like history of melanoma or history of basal cell or whatever in
Oh,
your
I still
assessments,
do
or do you
that
still do that? Yeah. Okay.
because that's today's question is I ask the history of their follow-up questions. Are you having a headache? Are you having, like we're ruling out Mets, right? At that point. But I know that I'm never going to miss that that patient does have a history of melanoma if it gets buried in their 100 basal cells, if they're like the sidebar, right? That is the most these are the most important things that I never wanna miss.
So, Ellen, this was fantastic and lots of really helpful tips today. For those of us who want to learn more from you, who want to hear more about these tips to utilize for documentation, how do we reach you? How do we find you? Are you on social media? How can we connect with you?
Yeah, I'm on LinkedIn mostly. I scroll too much to be on Instagram and stuff, but you can email me at ellentderm@gmail.com. You can honestly reach out. I will talk your ear off about this kind of stuff. I'm super passionate. I'm on podium about it. I wanna do podcasts. I wanna do stuff like that. I wanna make your life easier, I promise. So I'm very, very passionate about it. So please reach out to me. Please do.
We are so honored that you came and spent a little bit of time. I think that, it's just so important for all derm PAs and NPs to know that there are charting resources out there. There is help for those people who are drowning and who are doing so many notes at the end of a day. There are people who love figuring out these efficiencies and love kind of figuring out the system. And I'm so glad that your brain loves this because I just love picking your brain about it. But there are instructions, there are guides, there are system tools that can help people, and they're available to all of us. It's not just, hidden. It's not just in your IT's, kind of memory bank. I think it's wonderful to remind ourselves that we are all very smart providers and truly we can help ourselves be able to help more patients, right? Isn't it wonderful if we're more efficient, we're able to help more people? So, any final words, Ellen? Anything else that we need to know or that we didn't ask you about?
No, I guess just big picture, documentation is not busy work. It's an investment in your patients and in yourself and in your free time.
Beautifully said. Thank you so much for being with us today, Ellen.
Yeah, of course. Thank you so much for having me.
Thanks again for joining us.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.